For the staff, all healthcare workers should be vaccinated against hepatitis B. If any intravenous, intramuscular, subcutaneous, intradermal, or mucosal contact with blood products, or any body fluids occurs, you must attend occupational health for risk assessment as a matter of urgency. Hepatitis B vaccine or immunoglobulin may be given if necessary, and this is best done within 24 hours of the event. For the visitors, no special precautions unless patients are actively bleeding, leaking any of the fluids, in which case gloves and aprons should be worn. For patient transfer, the receiving department or ward must be notified of the patient's hepatitis B status. Finally, let's talk about an educational case for hepatitis B virus. A 28-year-old female presents to the clinic with a 10-day history of flu-like symptoms, including anorexia and malaise. She does not report any pertinent prior medical history or surgeries. She takes no medications. Her family history is non-contributory, and she reports no sick contacts. She is sexually active with multiple partners and has used oral contraceptives regularly for the past 12 years. She has not traveled outside the United States in the past 5 years. On physical examination, she is alert and oriented, in no acute distress. Her vital signs are temperature of 99.9 Fahrenheit, pulse 78 per minute, respirations of 18 per minute, and blood pressure of 121 on 78 mm Hg. Her extraocular muscles are intact, however, mild scleral icterus is noted. Heart sounds are regular rate and rhythm without murmurs, and lungs are clear to auscultation bilaterally. The abdomen is soft and non-tender, except the liver is tender when palpated and extends 8 centimeters below the costal margin with a smooth edge. Initial lab testing is performed and is the following: alanine aminotransferase ALT, is equal to 3817 U per L. Aspartate aminotransferase AST is 2152 U per L. Alkaline phosphatase ALP 176 U per L. Albumin 3.4 gram per DL. Total protein 6.7 gram per DL. Total bilirubin 8.5 milligram per DL. Given the clinical history, what is a broad differential diagnosis? The differential diagnosis for a patient with flu-like symptoms and enlarged liver and scleral icterus is broad and includes hemolytic anemia, hepatotropic viruses, and other sources of liver injury, such as autoimmune disorders including Sjögren disease and primary sclerosing cholangitis, drug-induced, example acetaminophen, and chronic alcohol abuse. HIV must also be considered. The history and viral serology studies will help to narrow this differential. How does the initial hepatic panel help narrow the differential diagnosis? The initial hepatic panel shows very elevated aspartate aminotransferase AST and alanine aminotransferase ALT, while the alkaline phosphatase is relatively normal. A low albumin may indicate liver dysfunction. However, the patient's albumin is only slightly low. Elevated total bilirubin may indicate hemolysis or liver dysfunction. When AST and ALT are highly elevated, particularly when disproportionately elevated compared to alkaline phosphatase, acute hepatitis must be strongly considered in the differential diagnosis. Classically, AST is significantly higher than ALT in the setting of alcoholic hepatitis. These patients will also likely have a history of chronic alcohol use. When ALT is higher than AST, viral hepatitis is favored. A thorough history and assessment of risk factors can help to determine which of the viral hepatitis types is most likely involved. So, what is the most likely diagnosis? Given the patient's representation of flu-like symptoms with jaundice and tender hepatomegaly, acute viral hepatitis must be considered very high on the differential diagnosis. Her history of multiple sexual contacts without barrier protection is a risk factor for hepatitis B in particular, as well as HIV. As said above, the CBC is normal, ruling out anemia, and the BMP is also within normal limits. The diagnosis can be confirmed with viral serology. So, viral serology is ordered. The results for viral serology are hepatitis B surface antigen positive, hepatitis B e antigen positive, IgM anti-HBC positive, IgG anti-HBe negative, IgG anti-HBs negative, HBV DNA positive. Being said, IgR immunoglobulin and the E in hepatitis B e antigen is envelope. How does the hepatitis serology help narrow the differential diagnosis? By the results said above, we can deduce that the serology is positive for hepatitis B. Now for diagnostic findings, part 3. The patient's disease state, active infection versus cleared, immunized, acute versus chronic, can be better characterized using viral serum markers. For the markers, hepatitis B surface antigen, if it's present, it indicates active infection. Hepatitis B envelope antigen, which is a replication marker, if it is present, it indicates active infection. IgM anti-HBC, which is an antibody against core antigen, indicates acute infection. IgG anti-HBe, which is an antibody against E antigen, indicates prior exposure, cleared or chronic infection. IgG anti-HBs, which is an antibody against surface antigen, indicates prior exposure, cleared or chronic infection with a history of vaccination. If we have isolated findings for HBV DNA, which is the viral DNA, it indicates an active infection. What are the possible clinical outcomes of hepatitis B? Once exposed, a patient may experience an acute symptomatic viral hepatitis accompanied by an immune response. A healthy, immunocompetent patient will likely be able to clear the infection and become subsequently immune, whereas other patients, particularly if they are immunocompromised, are unable to completely clear the acute infection. These patients will either progress rapidly to liver failure or slowly to possibly cirrhosis, chronic hepatitis. It is also possible for a patient to experience a subclinical hepatitis after exposure and progress to chronic disease without ever manifesting acute hepatitis. Chronic hepatitis B also carries increased risk of developing hepatocellular carcinoma even before progressing to end-stage cirrhosis. Known patients with chronic hepatitis B from high-risk populations should be monitored for this complication via a combination of liver ultrasound and alpha-fetoprotein levels. What are possible treatments of hepatitis B? Acute hepatitis B requires only supportive treatment while the patient clears the infection. Antiviral medications have not been shown to shorten or improve the course for patients with acute hepatitis with severe presentations. Patients with chronic hepatitis B should be treated with interferons and antivirals and regularly tested for viral loads and liver function markers to monitor for progression, increasing viral load and or declining liver function. Virus HBV poses a significant public health threat. However, effective preventative measures, particularly vaccination, offer a strong defense against this chronic infection. Therefore, maintaining high vaccination rates and continued research into treatment advancements remain crucial for mitigating the global impact of HBV. These are the references used for the presentation, and thank you for listening.